Small County Fiscal TA webinar with Mike Geist. We're going to get started in just a few seconds. Just the usual details. You're all on mute. So when you want to ask questions, and Mike will be stopping regularly to ask the questions, please type them in the question box or click the hand icon next to your name, and I'll be able to unmute you and let you ask your question. We're recording this, as we always do, and you will be able to find the recording on our website within the next couple of days. And I think that's all I need to tell everyone. So here's Mike.
Great. Thank you, Shoshana. Good afternoon, everybody. This call will be covering the issues discussed at the Joint Financial Services Information Technology meeting that was held last Thursday, March 5th. You can see the usual list of topics that we're going to cover there. And jumping right in with drug Medi-Cal update. Hopefully you're aware that DHCS issued Information Notice 15-01 that describes the claiming process for drug Medi-Cal beneficiaries who are also members of a Medicare Advantage plan. And in that information notice, it describes, and let's see, here's the information notice here. It describes the circumstances under which you can bill directly to DHCS rather than having to try to bill through and get the denial from the Medicare Advantage plan. And you can see here the situations that that must exist for that to occur. But anyway, you definitely want to take a look at this. There's also an attachment that has the letter that the Medicare Advantage plan would submit to DHCS so that they could enter that into the system and know that that you can bill directly for drug Medi-Cal services. Basically, the process is similar or almost exactly the same as what is done under Medi-Cal, especially mental health services. The one thing, though, that we did hear in the meeting was that DHCS is still working on how to actually implement the information notice in the claims processing system. So, but the information notice is out. You definitely want to try to get to the extent that there's a Medicare Advantage plan that your beneficiaries are a part of. You're going to want to get that letter in so that you can bill directly for drug Medi-Cal services. We also talked about the emergency regulations, and if there's really two different sets. There's the physician diagnostic requirements, emergency regulations, and so really there it kind of deals with this first bullet. The counties have been told informally that physician prescribed doesn't mean a face-to-face visit, but we really want some sort of formal written guidance on how to document that the physician prescribed regulation requirement is being complied with, especially when we get to audit, and so basically knowing what the auditors want to look at or what they'll accept. So that request was made of the state regarding the physician diagnostic requirements. And then we also talked about DSM-5 and ICD-10. And so it sounds like ICD-10 is actually pretty far along, that the state will be able to implement that on October 1st. And they continue, they're working on it, but they're pretty far along in that. But apparently not as much on the DSM-5. It sounds like they are just having some of the discussions around how to implement. The existing regulations right now, as well as contracts, specify that it's you're required to use DSM-3 or 4 And so those will have to be updated once DHCS is ready to implement DSM-5. The counties also wanted to know whether the state anticipated doing a strict cutover to DSM-5, or was there going to be a transitional period where you could submit claims, it sounds like, under either any one of the DSMs. And so basically the state just took all these questions and will get back to us. DHCS also indicated that they're ready to test the ICD-10 with the CSI system, but it sounds like the counties have just informed their vendors on the ICD-10 requirements, and so it's going to take a while for the vendors to make the changes. So basically the counties aren't ready to test that with the state, and so we're just not ready yet. So so that was it on the emergency regulations. Are there any questions on either of those two? All right, moving into the cost report update. We received another update on the 1314 cost report. It sounds like they intend to issue the forms and instructions, and this is the drug Medi-Cal, or substance use disorder cost report. They intend to issue the forms and instructions by the end of this month, and then they anticipate having the actual Paradox application ready for release the beginning of May. And then the state specified that they will give you the usual amount of time to complete the cost report, but they didn't provide a specific date as to when that would be due. As well as we've also, this isn't really anything new. I know they've been trying to get this out for a while, so hopefully they can get it out by the end of March, the forms and instructions, and then the Paradox application, so you guys can get that thing done. We talked real briefly about the administrative claiming, that there is the information notice out that we've talked about before. If you want to do administrative claiming for drug Medi-Cal, the state provided an update indicating that they anticipate processing some of the initial claims next month. So hopefully you'll start to see some payments this fiscal year for those of you who went through the process of preparing that claim. We also were provided an update on the quality assurance utilization review claiming, because right now the state doesn't have anything in place for drug Medi-Cal quality assurance utilization review claiming, but they have requested funding for those activities in the state budget, and they anticipate or intend to issue an information notice in April, so that you could begin claiming May 1st, hopefully, for your QA activities in the drug Medi-Cal program. Are there any questions on that? All right. We talked about the NTP group size. So these are the larger group size, 200 plus minutes. That is included in the recently submitted state plan amendment. It has not, I guess, been approved by CMS, but at least is in the state plan amendment. And apparently there are no system edits in place anyway, so you can go ahead and submit claims with these larger group sizes now, and the claims should get approved and processed. So it sounds like you can go ahead and do that. And then again, the counties expressed concern about the impact of the behavioral health subaccount allocations on the SAPD MOE requirements, and really it's related to the mingling. I don't want to say mingling. Just the way the behavioral health subaccount isn't specific to a program, and how is the state going to look at that with respect to the SAPD MOE requirements. The other part that plays into this is that there was a minimum drug Medi-Cal allocation that is currently in place of $100,000 for all counties. So even if you aren't doing drug Medi-Cal services, you're receiving additional money in your behavioral health sub-account based on this minimum drug Medi-Cal allocation of $100,000. And so the question is, how does all of this impact each individual county's MOE requirement, SAFTI MOE requirement, and if a county doesn't meet it, how is that going to play out? So CBHDA is crafting an email to ask specifically the question, I guess, and hopefully we'll hear back from the state at the next Financial Services Committee meeting. And that was it for drug Medi-Cal. Anybody have any questions or anything else on related to the drug Medi-Cal?
There is a question. What is NTP?
Narcotic Treatment Program, I believe.
Okay, that's it.
Okay. We then received an update on the Short-Doyle Modernization project, primarily from Cal Mesa. So you remember this project is the one where there's really three parts to it. One is to look at putting in place system enhancements to the Short-Doyle system to basically so it can continue to adjudicate and process claims, and some of the enhancements that we're asking for deal with the ability to reconcile approved claims and some of those things. There's also one of the objectives is to look at alternative fiscal reimbursement systems or methodologies, and as part of that, this is going to include a fiscal pilot where counties will be selected to kind of test some of this and see what works and what doesn't work regarding fiscal reimbursement systems. And then the third part of it is the longer term, which is creating both an entire reimbursement structure system and claims processing, or not even a claims processing, but a data processing system that supports the interoperability between mental health, substance use disorder, and primary care, so more interoperability across the system. And so Cal Mesa, the main focus really are the two first projects I discussed, and mainly this fiscal pilot, which is kind of the one that's being focused on right now. And so Cal Mesa is going to manage this. That was finally agreed to between CBHDA and Cal Mesa. They're in the process, Cal Mesa is, of identifying a contractor to assist with the technical aspects of the project, because ultimately the goal of this is to try different things, case rates, capitation, and see, encounter and see what works, what doesn't work, and to ultimately develop some sort of white paper outlining a proposed change in reimbursement system from what we currently have on the retrospective cost-based minutes of service system. So the contractor will help out with all those technical aspects of the project. Cal Mesa will be holding a future conference call, it sounds like, to discuss the selection criteria. I know some counties have already volunteered by emailing Sarah that they want to participate or want to be one of the test counties. And so there'll be a conference call to discuss the selection criteria with all the counties. And then once selected, those counties will have contractor support, so from the vendor, in terms of what to look at, the data, how to analyze it, those sorts of things. And then, one thing that's pretty clear is that this project's going to have to show a link between fiscal incentives and the service delivery system, so that, again, it isn't what we currently have, which is really, there really are no incentives. It's, as many minutes as you can document, you get paid for. So there'll probably have to be a link between the service delivery system outcomes, et cetera, and some fiscal incentives. So, but again, a lot more to come. This is something that'll probably take place I would think over the next 6 months or so. But again, more to come on that. And then we did talk briefly about the Short-Doyle 2, like system improvements or enhancements. I don't know if you remember, there was an initial survey probably done 4 or 5 months ago where counties were asked to identify and prioritize issues with the system. SWAT is relying on that survey as well as input. I guess they received some additional input from some counties recently, but that's how they're prioritizing the system improvements. And then if you have any questions or need additional information, you've got Sarah's email there, and you can contact her for additional information. Anybody have any questions on the Short-Doyle modernization project? All right, moving into the Short-Doyle 2 update. So Dan Walters provided an update from the CBHGA SWAT group. DHCS has issued Information Notice 15-008, which discusses claiming for beneficiaries in an IMD. And apparently SWAT has submitted several questions and they're waiting for a response. As we've heard before, SWAT developed a crosswalk between HCPC codes and CPT codes, submitted that to DHCS quite a while ago, and is still waiting for DHCS to review and comment. The SWAT, I guess, is also wanting to identify the Medi-Cal aid codes associated with foster youth, and apparently this relates more specifically to the King Gap aid code and whether that is tied or is not tied. There actually is in the aid code master chart, which I didn't pull up, but you can look here. In the aid code master chart, when you go to some of the, you'll see this title for the MEGs, which is Medi-Cal eligibility group. Some of these are foster care. So actually this is even showing the kinship is considered foster care in terms of how the state views it when they report to CMS. And DHCS did raise that they have that identified. But there also is some concern that maybe that aid code master chart doesn't correlate with what is in what KDA considers subclass members or what the EQRO is looking at in terms of foster care. So it sounds like the state will look into that and get back to us. And then Los Angeles brought up an issue. They're receiving, some of their claims are being inappropriately or incorrectly denied. It's denial code CO13, which is when the date of service is after the date of death. And Los Angeles said that is not correct, that should not be, that is not the situation. So they're working with the MedCCC. If other folks have that, you may want to let CBHGA know so they can get you in touch, or let MedCCC know if you're seeing that denial code, so that you can get part of whatever fix ends up being put in place for Los Angeles. Any questions on any of that? All right, then there was a question during the meeting about several different state published reports and what's happened to them. And the state went back and took a look and then provided an email that provided an update on some of these reports. And I listed the 4 different reports here. There's what's called the Short-Doyle Medi-Cal statement, which is listed on ITWS. And so you need to have access to ITWS and the cost and financial reporting section of ITWS, which is where you would load the cost report. And it tells you how you can get at that Short-Doyle Medi-Cal statement. There's also the direct services report, which is posted in the MedCCC library. So if you go to the MedCCC library, you can come down to this direct services county payment status. You open that up, and this is what it looks like. It provides FFP by warrant, EPSDT, state general fund, which is old, by warrant, and then receive date. The nice thing is it does give you claim schedules, file names, so a lot of counties use this to try to reconcile payments with their claim submissions and approvals. So that report is updated and is available on the MedCC library. And this last one is as of February 28th. There's also the KDA reports. And so again, you go to the website listed there, and about halfway down, it's got the Special Mental Health Services reports, and you can click on and see what data is being reported for your county on the KDA reports. And the one report that they're no longer posting is the timeliness report, which they used to produce here, which basically just outlined how quickly they were processing and paying claims. It probably isn't that helpful to counties because it isn't, I think it was more of an aggregate report, just kind of showing in general how fast they're processing claims. It isn't something you would be able to necessarily use for reconciling your data, your payments, your claims. So in any case, those are the reports that the other three they are continuing to update, but they're not doing the timeliness report anymore. Anybody have any questions on those? All right, then we got into the claims payment update. So starting off with the 9/10 Medi-Cal Specialty Mental Health Cost Report settlement, they've completed the reconciliation process with all counties, so I guess everybody has a clean 9/10 cost report. And based on that reconciliation, they identified the funding required to settle those cost reports, and it's included in the budget year, so 15-16 is when you would anticipate, if you're owed money based on the cost report settlement, that you would see those funds. And actually in 9/10 that could include EPSDT, State General Fund, as well as the federal financial participation. For the 10/11 cost report, they reported out that 23 counties have completed the reconciliation process, and those counties have been included in the budget year in terms of being able to fund the reconciled cost report for those 23 counties. It seemed to sound like the window was still open if you are able to, for those of you who don't have a clean cost report or who have not completed the settlement process. Sounds like if you do that fairly quickly, you could get into funding for the budget year. But if you don't, then you're looking at, and you don't, especially if you don't have it done, I would think by the May revise, if not probably a month or so in advance, you're going to be looking at having the funding for your reconciliation won't be in 15-16, but will be in 16-17. And this is all part of that new process that the state is implementing. They're saying, DHCS is saying it's Department of Finance that wants to have the actual numbers before, have the actual reconciled cost reports before putting amounts into the budget. What that really does is delays payment to you guys by another fiscal year in a lot of cases. And then we received an update on the 13-14 cost report. There's still problems with the summary template. However, there also are some errors with the detailed template, but those errors in the detailed template apparently only impact hospital providers. So unless you're completing that whole section of hospital worksheets within the detailed template, you should be able to go ahead and complete the detailed template. And for those of you with contract providers, that are not hospitals, you can go ahead and have your contractors use the detailed template that is currently posted to prepare their cost report. Obviously, there's an issue with the due date being last December 31st, and that's both in, I believe, statute and in your contract and in the information notice that they published to release the cost report. And there's been no formal communication to say that that due date has been extended. And this could be an issue with when you go through your triennial Medi-Cal, especially mental health audit. So DHCS is considering, I guess, different ways to try to communicate that the delay that they've created based on these issues with the cost report, so that you are not dinged as part of that audit, as well as so that other folks, maybe stakeholders within the county are saying, where's your cost report? And there's nothing really you can show them in writing that says it's delayed. But hopefully DHCS will issue an information notice or something that will allow you to show folks that that it's the state's issue and not yours. Any questions on any of that stuff on the cost reports? All right. So we talked a little bit about the electronic funds transfer process, and it sounds like they're getting real close, and so they'd like to pilot test this with some counties. They are currently in the process of identifying the selection criteria for how they're going to choose which counties to use as part of the testing. And if you're interested, go ahead and email Don Kingdon and let him know that you're interested in being part of the EFT pilot test with DHCS. We talked, or we received an update on the adjudication of claims with multiple aid codes. Again, this has been on the agenda for a while now. And DHCS is looking at different solutions. They didn't really say what those were. But they did say that they're going to go ahead and conduct a technical analysis, I guess their IT group, and they anticipate 4 to 8 weeks to really look into it and conduct this technical analysis. They then will bring the results of that analysis back to both the SWAT and to Financial Services Committee to obtain county input into how to handle this issue. And this issue, it sounds like it goes back to the beginning of Short-Doyle 2, which would be, I believe, January 1st, 2010. So again, more to come on this. Probably, I would bet they'll take the full 8 weeks, if not longer. And so we probably won't hear anything more on this for a little while. A question was raised by a county on the remittance advice that you receive on the FFP payments and how that only reflects the current fiscal year and does not show the date of service, which makes it difficult to reconcile. And basically the state said they understand that, but that's kind of the way it is, and they don't think they can change it. So unfortunately for you folks, it makes it a lot more difficult to reconcile things. Again, you can try to use those reports that we just went through a couple slides ago to try to reconcile, as well as hopefully your system can tell you which approved claims are included in which warrant and so forth. But it just makes it a little bit more difficult. But it sounds like the state doesn't anticipate any changes. And I think it has to do with just how the state budgets this now, where they budget everything on a cash basis rather than accrual. So the remittance advice just shows the appropriation from which the payment is coming from the fiscal year. And then we talked, hopefully you're aware that you have these interim rates where the state takes your most recently filed cost report and adjusts it for inflation and sets kind of a maximum rate that they will pay you at during the fiscal year. And so there's been some requests from counties to how do we modify those rates if we know in fact those rates don't reflect actual costs due to a lot of different things. If you're expanding programs, maybe doing some new programs where you have a bunch of startup costs. And so the state said they would look at that. We recommended looking at the 1115 waiver. There was some language in the prior 1115 waiver that gave county hospitals or public hospitals the ability to modify their interim rates rather than just locking them in solely to their recently filed cost report. And so hopefully there'll be some ability to use something similar to that because CMS had approved that. And you guys will have the ability to request changes to your interim rates because, again, the goal of the interim rates are to approximate actual costs, and especially in light of what I just said in the prior slide on the cost report settlement where they're really pushing that out another year to get that into different budgets, that you want those interim payments to be as close to your actual cost to lower the amount of settlement when you actually do the cost report. So are there any questions on any of that? All right, then we got into MHSA. The revenue and expenditure report 1213 is out, the information notice, and there's a due date of March 31st, 2015. Hopefully you're all aware of that. The 1314 MHSA revenue and expenditure report, they're saying to anticipate minor changes. I think there will be some changes because I think they have to add something in related to the triage grants, the SB 82 grants, and I'm not sure what else they're looking at changing, but it sounds like they're going to do some minor changes. They're hoping to release the template by the end of April and give you, they said 60 days, so I would think it would be by the end of the fiscal year, by June 30th or so, that you would be required to submit the 1314 revenue and expenditure report. And we talked a little bit about trying to develop a template and a process where the reporting requirements are actually provided ahead of the start of the fiscal year rather than 2 or 3 years following the close of the fiscal year. And it sounds like that DHCS and OAC may be looking to try to do something with, pending the outcome of the fiscal pilots and where we end up in terms of fiscal payment reform, or that we may have changes not just to the revenue and expenditure report, but also to the cost report to try to blend it all together and come up with one financial report for at least Medi-Cal, especially mental health, that encompasses MHSA, potentially even behavioral health, depending on where substance use disorders and drug Medi-Cal goes. So hopefully that will be something, down the line, maybe 16, 17, or 17, 18, coming out with an entirely different sort of approach, because under whatever payment reform we come up with, assuming we come up with something, it might not be tied as much to actual costs, and it definitely won't be tied to modes and service function codes. So it may give some opportunities for incorporating a lot of this stuff into one sort of report that's hopefully less complex than the reports that we do now. But again, this is very premature and early talking about this, and I think they'll get the 1314 out. I wouldn't be surprised if the 1415 comes out probably 3 months after that, and it may even be due the end of December like it should be for 1415 at the same time of the cost report. So anyway, more to come on all this, but just be aware that 1213 is due the end of this month, and 1314 will probably be due the end of June. All right, any questions on that stuff? And then we actually received an update on the allocation or distribution approach for MHSA funds, a little bit more concrete than what we've heard previously. So we have talked before that DHCS is considering making changes to the 15-16 distribution methodology, but apparently they're looking at considering 12-13 as the base year, which as of right now, that's the highest fiscal year in terms of distributions. And then they would allocate growth above 12-13 based on one of three different approaches, or a combination of them, I guess. One is just to kind of keep the status quo and just use the same percentages. The other is to keep the same formula but update the data. The data in the formula goes back quite a ways, and I don't believe they've updated anything in that formula probably since 8-9 or 9-10. And then they also said they may remove the uninsured from the formula because uninsured is one of the factors that came up with the percentages. Although to be honest, I think the second and third are probably going to be similar if they, because if they update it with current data, then you're not going to have as much uninsured because of the Affordable Care Act. But in any case, more to come on that. I think there's one of our biggest probably concerns is that 14-15, the year we're in now, is probably going to be the highest allocation year or distribution year. So then to try to go back to 12-13 as a base year could potentially hurt counties, and so we'd prefer not to have that happen, and I think we'd prefer to have 14-15 as the base. I think it's pretty clear that 14-15 is going to be the highest allocation. So anyway, more to come on that, and we'll see where it ends up going. DHCS did indicate that they published the MHSA statewide expenditure report, although I didn't see it on their website, but it was emailed out as part of the MHSA committee. And so there we provided a link to that report. That goes into detail, quite a bit of detail, on the use of the state administrative dollars. It does have some revenue projections, which are the same as what I've provided, just mine are more related to cash basis and the fiscal year in which you'd actually get the money. But it goes into a lot of detail if you want to take a look and see how the state is spending their MHSA share of funding. And then we talked a little bit about how MHSA is conducting MHSA-specific audits at this point. And I know that they've been in San Diego for a while, or at least that audit's been ongoing for a while. It was good to hear that the program staff are looking at the audits report, the report prepared by the auditors, to make sure that, in fact, any sort of findings or issues are consistent with programs' policies. What will be interesting is to see, since there is such little guidance, definitely little regulation, what are programs' interpretation of fiscal policies. So we'll see how that looks once that report is issued. The other thing that we brought up, and I think it was important to bring up while the state was there, is that one county who was under their Medi-Cal audit was being told by the auditors that they could not use MHSA funds as match for Medi-Cal, basically. And it was specific to administration, but it sounded like the wording in the audit was broad enough that it potentially could be considered for direct services. So the program folks said they would look into it and see if, in fact, that is the what the audit issue really relates to. and if it is, hopefully they will correct the audit staff, because there's clear clear policy in the Act that says to maximize FFP. In fact, so anyway, more to come on that as the state conducts more MHSA specific audits, and we'll see how that goes. Any questions on any of that? All right. Then we went into the state and federal budget update. We've talked before about this, how there's $600,000 of state general fund monies appropriated for the KDA quarterly progress reports in preparation of those reports. So the state is considering, and it sounds like they're pretty close to making this as the recommendation, to develop 3 or 4 different categories of distribution amounts based on the population size of the county. And so we'll see what that looks like once they come out with something a little more official. And then you would actually receive the distribution once your quarterly reports are filed. So I believe it's 50% with the first report and 50% with the second report is how the funds would be distributed. And so for those of you who have already submitted your KDA quarterly progress report, the DHCS would start to process the first 50% in April. So you may actually get some money this fiscal year related to that. But it sounded like, too, they were preparing an info notice or something more formal that would describe what they're doing with the $600,000. And then we talked a little bit about the 13-14 behavioral health subaccount growth, and we've talked about this before, where DHCS is going to use, or at least recommend using, the same process and approach that they did in 12-13, using approved claim amounts submitted through December to determine whether a county was underfunded for a combined drug Medi-Cal and EPSDT. They did indicate that they were considering or taking into account counties that had data issues. So I'm not sure who to contact. Probably MedCCC. If you have data issues or had data issues with your 13-14 EPSDT or drug Medi-Cal claims, definitely let DHCS know so that they can take that into account. So DHCS will make a recommendation. That has to go through their agency, through the Health and Human Services Agency, probably Department of Finance, and I believe CSAC probably gets to weigh in too. And so they anticipate the distributions in late May, just like last year. The one thing they did say is that the amount, so if their recommendation was accepted by everyone, the amount to make the counties that they considered underfunded whole was similar to last year. So that's good. That means that there will be, again, some general growth that everybody would get. Anybody have any questions on any of that?
There's a hand up. Raven Lopez, I'm going to unmute. All right. Raven Lopez, you can ask your question. Oh, maybe it was just a mistake.
All right. Then moving on to the workgroup updates. The main thing we're waiting on here is just the fiscal state plan amendment. Sounds like the state received some more comments back from CMS, and so they're going to respond to those and submit the state plan amendment formally to CMS. Once that state plan amendment is approved, they will release the claim forms for the supplemental claims, and these are for costs in excess of the SMAs. So it sounds like that will all occur hopefully next fiscal year and not the year after. It is included in the budget for next fiscal year. I think they've got about $400 million in DHS's budget to pay what they anticipate is the supplemental claims. That also assumes that their Office of Legal Services is willing to revise the criteria used to determine a nominal fee provider. I think you'll still have to go through the calculation, but the hope is that there's 4 additional criteria that the state has imposed that really actually shouldn't be imposed on a public provider. And so hopefully it'll be just the calculation. The state will hopefully give you the ability to do that calculation to show that you're a nominal fee provider for those of you who set your published charge at the SMAs. So again, more to come on this. CMS, once the state submits the state plan amendment, CMS, I believe, has 90 days with which to either approve or deny. So we'll definitely know by the end of this fiscal year, hopefully, whether at least the state plan amendment's been approved, and then also hopefully how the state's going to implement the nominal fee provider provisions. Any questions on that? All right, then moving into the other fiscal issues or the county-to-county stuff. Thad Dixon came and gave provided a discussion on these physician quarterly reporting system, and which I mean, the bottom line is he's going to put out, if you haven't already received it, he was going to provide a technical document around this, and it ties also into meaningful use, and there are Medicare incentives as well as Medicaid for complying with this, and I think he was going to lay all that out in this technical document that hopefully you, if you haven't received, will hopefully receive soon. So if you want to pursue that, you can. We talked a little bit, or actually there's a question on the SB 82 triage grant fiscal reporting, and it was brought up that there actually is a conference call this Wednesday from 2 to 4. There's a call-in number and participant code. Hopefully you all received the email from Susan at CBHDA that disseminated this information, as well as, I believe, some spreadsheets and some other things. But it sounds like the state's gonna talk about this on Wednesday. We talked a little bit more about the MHSA audits, and really it was more audits in general, and about seeing having the audit supervisor attend one of the upcoming financial services committee meetings, and what would we want to discuss. And a couple of issues that were brought up were, consistency among the auditors, as well as consistency among fiscal years, and then also what are some of the cost allocation approaches that are allowable, and how to use those. So we'll see what goes on there, and whether they're even willing to participate. And then we talked a little bit about Proposition 47 and whose responsibility it is for the competency restoration, and who's responsible for services. And it sounds like the CBHDA Forensic Committee is already looking into this, but it may be an issue that needs to be brought up to CSAC in terms of how, and bring county council in terms of how some of the judges are handling or implementing Prop 47 or interpreting it. And we talked a little bit about kind of had the same issue with some of the hospital costs, but really here too we do have a state hospital work group, which is, and actually this is specific to state hospital costs, I should have had that in there, but Cal Mesa has a state hospital work group, and so this would be an appropriate place to bring that issue up. And then lastly, you know, we brought up that we've got the CIBHS Fiscal Leadership Institute that is going to occur on May 19th and 20th. Hopefully you've received the flyer for that. We're in the early stages of setting that up, and so if there are specific areas of interest you would like to have presented, any topics, you can go ahead and email Shoshana those topics, and I'm sure she can try to work it in to the 2 days that are scheduled May 19th and 20th. There'll definitely, I would imagine, be something discussing the May budget revise, and there may be some information preliminarily on how the fiscal pilots are going with the Short-Doyle modernization project. But again, if there's specific issues that you're seeing that you would like discussed, definitely email Shoshana. And that's it. Any questions? Anybody have anything else to add? Are any hands being raised, Shoshana?
No, very quiet group.
Good.
Okay.
All right, then we'll finish up a couple minutes early, and we'll look forward to seeing you guys at Financial Services next month. Thank you.
All right. Thank you, Mike.
Bye-bye.
Bye. Bye, everyone.